It's fair to say that 2020 did not turn out the way any of us expected. I'm Dr. Hunter Cherwek, Vice President of Clinical Services at Orbis International. You might know Orbis from our Flying Eye Hospital, which is a teaching hospital on board an MD-10 aircraft. It's pretty incredible. I was supposed to be traveling with the Flying Eye Hospital this year, bringing training programs to local eye health teams around the world. Instead, like many of you, I'm working from home here in Virginia. But it's tough to complain. My team and my family are healthy, and I'm grateful for all that we're doing now with Orbis. Really though, I'd much prefer to be on the Flying Eye Hospital. Because for me, the fight against global blindness isn't just a job, it's a calling. I knew very early on in my career, while I was still in med school, what I wanted to do. There aren't many professions where a 10 or 20-minute cataract procedure can change not only an individual's life, but a family. You don't need an intensive care unit, you don't need blood transfusion. We can do cataract surgery almost anywhere, and that can change someone's life forever. So in 2005, the day I finished my ophthalmology residency, I joined the Flying Eye Hospital team and I never looked back. It's been a heartbreaking decision to ground the Flying Eye Hospital when COVID hit. But just because things haven't gone as planned this year doesn't mean that our fight against global blindness has come to a halt. From here in Virginia, I'm working with my colleagues around the world to innovate, adapt, and create new solutions and ways to move forward. And that's what Sightlines is all about. I'll be your host for this series, looking at how Orbis is responding to COVID and tackling the overwhelming challenge of global blindness. Together, we'll explore how the pandemic is adding new challenges to this fight, and how the spirit of innovation that led our founders to put a hospital on board a plane is helping us overcome those challenges. There are some things we can't do right now, but right now we're focused on what we can do and what we're doing very well. Before we get going, let's take a look at why global blindness matters so much and what's being done about it. Here's the problem. Hundreds of millions of people around the world are blind or visually impaired, and most don't have to be. An astonishing 75% of these cases could be treated or even altogether prevented. I'm constantly thinking about how much good could be done in the world by restoring the eyesight to these millions of people. What it would mean for the people's individual lives, for local economies, for education, healthcare, and the cycle of poverty. And the thing is, we can bring the gift of sight to millions of people. The remedies very often are quite straightforward. A pair of glasses, a 10-minute cataract surgery, an annual dose of antibiotics to prevent an infectious blinding disease called trachoma. These things alone could restore sight or prevent blindness for millions of children and millions of adults. The challenge is to get this sight-saving care to the people who currently don't have access in places like Bangladesh, Peru, Vietnam, Ethiopia, Bolivia, India, Guyana, and beyond. Right now, that's a bigger challenge than ever. Orbis's mission is to work with a network of partners around the world to mentor, train, and inspire local teams to fight blindness in their communities. Training is at the very heart of what we do because it takes a skilled worker to do eye exams, perform cataract surgeries, and get that sight-saving care to the people who need it. But in-person training projects aren't possible right now. So what can we do? A lot. First, we're taking steps to support our partner hospitals around the world. That means helping them implement safety measures so that emergency eye care for conditions that must be treated immediately can still be delivered as safely as possible. Second, we're looking at how programs can be reshaped and optimized for the current situation. In India, for instance, Orbis has a long-running program called REACH that provides basic eye screenings and glasses to children in schools. With schools closed, however, the usual REACH activities can't happen. So instead, REACH teams have been redeployed to help treat emergency eye cases in hospitals. And what about the Orbis Flying Eye Hospital? Well, it was supposed to be in Zambia, Cameroon, Mongolia, and India this year, and nothing can replace the hands-on training that would have happened on board. But while the plane is grounded, we've moved the training projects online. Our team has crafted online courses tailored to the needs of each country's ophthalmologist, residents, nurses, biomedical engineers, and technicians who would have been joining us on board the Flying Eye Hospital. So they're still getting critical education and support to help save sight in their own communities. Moving the Flying Eye Hospital projects online is something that's possible because of yet another Orbis program, CyberSight. CyberSight is our distance learning and telemedicine platform. It was created in the early days of the internet. It has grown and expanded over the years, and it's taken on all new importance during COVID. In the past, CyberSight allowed us to continue to provide training and support in places where our plane or our team could not go due to cost, logistics, or security. Now, as the world manages a global pandemic, this technology has been essential to allowing Orbis to continue our mission. We'll explore all of this and more throughout this series. To get started, today we're going to take a close look at how the fight against COVID intersects with the fight against another infectious disease, blinding trachoma. To help us do that, I invited Dr. Danny Haddad, Chief of Programs with Orbis, on the show. Here's our conversation. I'm really excited to have Danny Haddad as our guest. He is our Chief of Program. Danny has a very interesting background in global ophthalmology. You started and joined the Orbis family in 2016. Maybe you could talk a little bit about your career before that and what led up to your joining Orbis.
After I graduated as a medical doctor, I started working as a volunteer in West Papua in Indonesia and managing a cataract program there. From there on, I went to Niger and became the regional coordinator for river blindness or onchocerciasis and trachoma. And that really introduced me more into the neglected tropical diseases, as we call them now. These handful of diseases that are infectious diseases that are easy to treat and prevent, and that are on an incredible path to being eliminated out of this world. And one of the ones that I've worked mostly in is a disease called trachoma. And the first time that I got, at least that I still remember as kind of my first patient that I saw with trachoma, was a patient in 1996 in Ethiopia. And basically I was spending a day in the outpatient department with an Ethiopian ophthalmologist. And then there was this one patient who had the complaints that every morning when she woke up, she had to put margarine underneath her eyelids to make the blinking go smoother. And I had no idea what that was. So when we examined her, we saw that her whole eyelid had rotated inwards and all the eyelashes were scratching over her cornea. And her cornea had already completely gone white. So normally when you look at somebody, you see kind of the clear part, the window of the eye, behind which you have the colored part, the iris. In this patient, it was completely white. It was so scratched, scarified that she couldn't see anything anymore. And the ophthalmologist explained to me, well, this is trachoma. And this is an infectious disease that starts very early in life. It's a bacterial disease. And it starts in young children, and you get reinfected over your life. And every time you get infected, you get these little blisters on the inside of your eyelid that will heal with a tiny little scar. But over your life, since this disease is so endemic in these communities, you get so many of these little scar tissue formation on the inside of your eyelid that your eyelid shrinks on the inside and makes your eyelid rotate inwards. And that condition where the eyelashes scratch over your cornea is what we call trichiasis. And actually, the next day, we were traveling together to one of the clinics where they were doing outreach, where they would be seeing patients much closer to their home to screen them, see who needed treatment, surgery, and take them back to the base hospital. And we passed this field with a couple of young boys herding cows. And the ophthalmologist told me, said, I bet if we stop and we examine these children, all of these boys are going to show signs of trachoma. I said, I would love to see that. So we pulled over, called the boys over, and we flipped their eyelids and looked for these signs of trachoma. And indeed, all of them were infected with trachoma. And it's so amazing to see that now. I mean, this was in 1996. The incredible progress that we have made in this area with these communities to make sure that blindness due to trachoma is very soon going to be something from the history books.
That's fantastic. I mean, obviously, this is something you've been fighting for 25 years. And before Orbis, I know you were leading a lot of the international efforts to eliminate trachoma. Maybe you can talk a little bit more about how trachoma is treated both medically and surgically, and how Orbis, especially in Ethiopia, is doing both.
Right. So when you're looking at trachoma and the different pieces of the disease, you're looking at the active infection with the bacteria, you're looking at those eyelids that are rotated inwards. We have a strategy that is called the SAFE strategy that really addresses all the different components of attacking the disease in a very holistic way. So in the SAFE strategy, the S stands for surgery. So once that eyelid has rotated inwards, we do surgery to evert the eyelid again, to make sure that those eyelashes are no longer scratching over the cornea and that progression towards blindness is halted. The A component stands for antibiotic, and this is where we look in a country at a district level to see if this district is endemic for trachoma. Is there a level of infection within the communities in these districts that warrant us to treat the whole district? And with this disease, we are not looking for individual patients and treating with an antibiotic the individual patient. The antibiotic that we're using is Zithromax, which is produced by Pfizer, and it's a very well-known antibiotic and very safe to use. And Pfizer is donating all the Zithromax that we need to target this disease. And basically what we're doing is that those districts where there is trachoma, we treat everybody in the district to make sure that we treat each person that is infected and reduce that way the burden of the disease in such a way that you do not transmit it to each other anymore. And then we have the preventive ways. We want to make sure that once we have suppressed all the infections in the community, that it stays down. And we do that by face washing, the F component, and the E component, environmental improvement. Basically, this means that we are doing a lot of work in schools, training children to every day wash their face and wash the discharge away from their eyes and from their nose, because that is really a way to transmit the disease from one person to the next. We're working at these communities to look at how do we make sure that these communities have access to water, because if you have to walk for an hour or two to get a bucket of water, the last thing you want to use that for is washing your face and using that for hygiene purposes. So we're really making sure that people have access to water closer by, and that they will actually use that water for hygiene purposes, for washing their face, and making sure that in that way we prevent the spread of the disease within the communities.
No, that's fantastic. And I mean, just so our viewers and our listeners know, we've had a Orbis Ethiopia office for more than 20 years. Today it has over 70 people, full-time employees that are really, really focused on this disease that Danny's talking about called trachoma. Every year we distribute over $200 million worth of the Zithromax antibiotic that is donated by Pfizer, and we're going out to the most rural communities, the ones that are at most risk, to help reduce the burden of this bacteria that causes this blinding disease called trachoma. And correct me if I'm wrong, Danny, obviously you're a trachoma expert, but I mean, trachoma was even in Ireland 50, 60 years ago.
Absolutely. In the Netherlands, in Amsterdam, in certain parts of Amsterdam, up to the Second World War, there was trachoma endemicity. And there's still a lot of literature from those days around trachoma in Europe. Trachoma has been around for thousands of years. If you're looking at some of the pyramids in Egypt, they're actually hieroglyphs where there is a sign of a pair of tweezers, because people knew that with trachoma, with the eyelids rotating inwards and the eyelashes scratching the cornea, that you had to epilate your eyelashes to make sure that you prevent going blind. And we've seen evidence that this already happened back in the days of the early Egyptians. So this is a disease that has been with us for a very long time. In America and Europe, we've been able to overcome this disease by the preventive measures around hygiene, by making sure that we have flushing toilets, that we have running water, and that we're able to provide to the whole community that level of hygiene that will protect us from getting the disease, from transmitting the disease. And I always love it to look at, we're here in New York, Ellis Island, the island where all the immigrants from Europe used to come and where they were screened. And one of the elements that people were screened for was trachoma. And most of the people that were refused entry to the United States in those days were actually sent back to Europe because they had trachoma. And it was one of the most feared elements at Ellis Island to introduce into the community. And that's actually part of one of my favorite movies, The Godfather. In The Godfather Part 2, where Vito Corleone arrives in New York at Ellis Island, you see in the movie how they flip his eyelids and that they examine him for signs for trachoma. We also see that they give him a chalk mark on his collar and that he's sent away, but somehow he was allowed to come into New York with all the consequences afterwards. But it does show the importance that this disease had in our community here in the US and in Europe in those days as well.
Yeah, and I think one of the things that's been most exciting, you're very strategic with how we're attacking trachoma in southern Ethiopia, and you have this beautiful map where we're looking at the prevalence before and after treatment and surveillance, even after the mass distribution of these antibiotics. Can you talk a little bit about how far we've come in Ethiopia with the mapping and all the epidemiologic studies that you've been doing? Could you just talk about how much success we've had in Ethiopia?
Absolutely. And this is something where over the past 10 years, we've made a lot of progress around looking at how long does it take to get rid of trachoma in an endemic district. And we're looking at what is that baseline that we're starting at in these districts. So how much of the community is infected? And we do that by going around a district where we select at random around 20 villages. And in those villages, we select a random number of households. And in those households, we examine everybody. And then we look at the children 1 to 9 years. How many of the children that we've examined have signs of trachoma? And that is what we're using as our baseline of where we are in that district. And based on that, we determine how many years of treatment we need to do with Citromax before we assess that district again to see what our impact has been. And we really want to make sure that we show that progress, that we've gone from, say, 40% of the children have trachoma to 5 years later, that we're reaching a goal of less than 5% of those children having trachoma signs. And when we are reaching that level of a district having less than 5% of children having signs of trachoma, that's when we can say, we think we've done it. And then we wait for 2 years. And after 2 years, we assess again. Is it still gone? Or did it come back? And do we need to start treatment again? Or can we really declare that we have eliminated trachoma in this district? And what I'm most excited about is that when we're looking at the map of Ethiopia, and a lot of the original, what we call mapping, so those assessments and really looking at what districts are endemic, when we're looking at the map of when we finished all the mapping in Ethiopia back in 2013, there was an incredible amount of districts that were called red, of being very endemic for trachoma. When we're looking now, it is incredible to see how many of those districts have turned green, where we've eliminated the disease. And it's just incredible to see the amount of progress that we've made over the past years and that we're continuing to make in Ethiopia. And for this year, we're hoping to look at treating, again, about 10 million people and bringing those communities really closer to that elimination of blinding trachoma.
And obviously, all of us now in today's world are very aware of infectious diseases and how to prevent the spread of transmission of diseases with COVID. Danny, we're going to be talking with the team in Ethiopia as well, but could you just talk about how COVID has impacted our work in trachoma?
Right. And this is, of course, where we are looking as Orbis, especially in Ethiopia, for this year to treat about 10 million people in the southern nations and nationalities state in southern Ethiopia. And one of the elements that we're looking at here is we have developed an infrastructure where we work together with the regional health bureau of that state to train at the district level, at the community level, volunteers that will go around and hand out the Zithromax. And the most fascinating part is that we actually do the dosing based on height. So they will walk around with a dosing pole, measure the height of the person that they're treating, and based on the height, either a child will get a specific amount of oral solution, a drink of Zithromax, or adults or all the children will get the exact number of tablets that they need. So this training and, of course, that distribution in the community is something that we're very carefully looking at. How do we do that in a safe way? How do we make sure that when these volunteers, these distributors, go house to house or bring people together in the center of the village, that we are not spreading the disease? So we're looking very careful, and we have a whole risk assessment strategy where we're looking at how do we make sure that the distributors that we are using and that we are training will be having the protective equipment that they need to protect themselves. Because we want to make sure that it's both the people that we work with that help us do the distribution, but also, of course, the people that we serve, that everybody is staying healthy and safe during this distribution program. And we've looked at it, we've discussed this with the Ministry of Health in Ethiopia, we've discussed it with our partners, the World Health Organization, to come up with a strategy for us to be able to do this in a safe way. As it stands right now, we think we can do it, and we think we can do it in a safe way to make sure that we are not going to eliminate trachoma, but start spreading COVID, because that would, of course, be counterproductive, counter what we are standing for. We want to make sure we can do the distribution of Zithromax in that safe way.
Yeah, and I mean, it's incredible to see what you've built with the team in Ethiopia. We have this incredible network for supply chain, for community education, for community volunteers. Do you think there's an opportunity where the Ministry of Health and in their COVID response could piggyback or use the already existing Orbis infrastructure and networks to help with COVID education and prevention, especially with all the hygiene work we're doing with trachoma?
Absolutely, and this is work that we've been doing over the past months. We're looking at how do we adapt the messaging that we had for face washing. Now, they're very similar, but not identical to the messages that we want to have around hand washing. So we've been working with our volunteers around changing the messages, some of the posters, educational materials, from face washing to include the hand washing messages. So this has been work that we've been doing over the past months since the early days of COVID to really enhance that awareness and the hygiene creation that we need to do in these communities to make sure that we keep COVID at bay. But I would like to actually take it a step further. One of the discussions that we're having as well is, of course, the success of the trachoma program. In our program in Ethiopia, and we're looking now at trachoma is endemic in the majority, almost all districts in Ethiopia. And right now, 70% of the world's burden of trachoma is in Ethiopia. Is this infrastructure going to be an opportunity for us to look at using for when there is a COVID vaccine? We are, with our strategy around distribution of Zithromax, able to reach more than 90% of the population in those districts. That is totally different than other vaccination programs. The current vaccination programs are really targeted at children. They're not targeted at the whole population. And this is where I see an incredible opportunity for us to look at how do we use this network that we have developed in all the communities and all these districts in Ethiopia to facilitate the vaccine distribution, the vaccination campaign around COVID-19 in Ethiopia and other places where we're working around trachoma. Because we're also doing work on trachoma in Zambia, although at a smaller scale than Ethiopia, but we're also involved in Zambia in the trachoma elimination. And what are the opportunities for us to use that incredibly strong infrastructure in other ways as well?
This podcast, just so everyone knows, was made possible by the generosity of an anonymous donor who wanted more people to know about Orbis and our fight against avoidable blindness. Danny, from your perspective, why is this fight so important? Not just to you and Orbis, for society and the world. Why is this fight against avoidable blindness so important?
We're looking, first of all, with prevention of blindness and restoring sight, which is possible in patients with cataract. Still, about half of the people in the world that are blind are being blind because of cataract, a very simple surgery. We are working with diseases that once they've blinded somebody, you cannot restore anymore. Unlike cataract, where once you're blind, you can restore sight again. But patients with diabetes, if they go blind because of diabetes disease, you cannot restore their sight. With trachoma, if somebody goes blind because of trachoma, we cannot restore their sight. When we're looking at the economic impact that blindness has on communities, we need to address prevention of blindness. We need to make sure that this becomes part of the health system structure in these countries to make sure that we break through the vicious cycle of poverty. When you're looking at individual level, and studies even here in the US have really shown that somebody who is blind is 4 times more likely to be depressed, to really value their life much, much less as people that have sight. So we're looking at the quality of life of people. When you've seen somebody who was blind for 7 years, and then the bandage goes off, and you see the change in their smile, that they're smiling for the first time in ages. When you see that change in their face, you know that this is something that has just got an incredible impact. But it's not just on that individual person's level, it is on the community level, it is on a whole different scale that we have an impact with prevention of blindness.
Yeah, and I think that's what so many people don't realize is how much of the world's blindness could be prevented or treated, and that's what Orbis does. And so much of that blindness right now is in low to middle income countries where exactly we're focused. Now is the best time ever to be in medicine, where we have all this amazing technology, we have this amazing connectivity, and now research, academics, everyone is focused on how their solutions can be globalized. And so I'm really excited, and I want to obviously thank this anonymous donor, because this is the first time we've had a platform to talk about our fight, and that it's something that we can achieve in our lifetime, where we're going to be able to give people hope and give people sight, where 20 years ago, we wouldn't even think that would be possible. That was Dr. Danny Haddad, Orbis's Chief of Programs. From helping to establish pediatric eye care centers across the country to eliminating blinding trachoma, Orbis Ethiopia has had a huge impact on helping millions of people to have access to eye care in the country. I recently had the pleasure of speaking with Dr. Alemayehu Sisay, Country Director of Orbis Ethiopia, to get his perspective on the impact that COVID-19 has had on delivering eye care programs, especially in the rural communities of southern Ethiopia. Here's some of our conversation. Maybe you can just tell a little bit about Orbis Ethiopia. How big is the team, and kind of the role of a country director?
Orbis Ethiopia has been operating in the country for the last now 21 years. A model eye care program was developed mainly in southern Ethiopia, providing cataract surgery, refractive error service, trachoma management. So since then, our program has been expanding, providing eye care service to more than 20 million population in the southern region alone. If we add the national program, our total beneficiary will be increased to more than 30 or 35 million, because we have projects in the northern Ethiopia, in Oromia region, in southwestern Ethiopia, and other regions as well. When Orbis started, it was only the country director and few supporting staff. Now we have more than 72 staff, and 27 of them are based in the Addis office. The remaining are based in the project area. where we have the actual implementation going on. I'm very fortunate and privileged to have my team with me, very supportive, very dedicated, committed, and they are working hard to meet the noble cause of Orbis. In Ethiopia, trachoma is the leading cause of blindness, second to cataract. So that indicates the huge burden of trachoma. And as you know, blindness and poverty are interlinked, so they create a vicious cycle. So if a person is blind from trachoma, the likelihood of its effect on the family is massive. People have to take care of the blind person, taking to religious places, markets, and other social events. So the consequence of being blind from trachoma is tragic. Mothers and children are affected disproportionately than men. Culturally, mothers have close proximity with child care. So the cycle of infection between mother and kids are so severe that mothers at the age of 35 and 40 could develop the blinding form of trachoma. And in Orbis, we are trying to provide services closer to a community so that accessibility could be improved. And we encourage mothers and kids to come forward for services. In our trachoma control program, our data indicates that more than 75% of the beneficiaries are mothers and kids. That is a huge progress in terms of addressing the gender imbalance.
In the years that we've been present in Ethiopia, we've had a huge impact in lowering the community burden of trachoma. Maybe you can talk about how COVID has slowed that down, but also how you plan to start back up. How do we plan to tackle now both COVID and trachoma in these communities?
So both trachoma and COVID requires personal hygiene. So how can we leverage the information, the resource in doing that? So I think we are doing in that line. We are merging the message through radio spots, through our health cadres at community level, at district level, and so on. In fact, we are sponsoring radio spots in some of our projects to propagate about the importance of sanitation for both COVID and trachoma. We have also provided a hand washing facility to some of the primary eye care units, including secondary eye care units. That indicates how we can work in the face of COVID by addressing the sanitation aspect of the problem.
That's a great answer. And obviously, you've been working now for years on rural outreach, community education, drug distribution, screening, and evaluations. So do you see an opportunity for the Ministry of Health and the Ethiopian health leaders to piggyback or use our backbone and network that we're already doing for trachoma to address COVID response, COVID education, and COVID control measures?
Absolutely, Hunter. I mean, we have to use the existing system to propagate information to address the problem. So the healthcare system, the health professionals are the same. The reporting lines, the district offices, the regional health bureaus, they are all the same. So they are coming up with an integrated approach to address COVID situation in trachoma, particularly, as I have said, on the infection prevention side, the sanitation and the hygiene component. We are using the existing policies, resources to leverage, the COVID on top of that. So in that way, we are trying to address in a very integrated and concerted way both trachoma and COVID.
No, that's fantastic. I mean, I think all of our viewers can see the similarities, whether you're trying to contain the disease of trachoma, which Ethiopia has been a leader in for years, or now COVID, which the entire world is affected, and looking at the response. I remember when I first was there more than a decade ago, and we were talking about what would it take and when could we achieve success over trachoma. And I never thought that would be possible in my lifetime. And, certainly there's still a lot of work, and COVID has made that work more difficult. I am very confident that with your leadership, Alemayehu, that we are going to win this war in my lifetime and make the Ethiopia state just like the UK and the US and Ireland, where we've rid the disease so no child has to worry, no parent has to worry about their child going blind because of a disease or an infection they got as a child. That was Dr. Alemayehu Sisay, the country director for Orbis Ethiopia. Before that, we had Dr. Danny Haddad, Orbis's chief of program. I want to thank them both for being part of this episode. Thank you for joining me for Sightlines today. I hope you'll join us for the next episode and for the entire series. If you'd like to learn more about Orbis and the Flying Eye Hospital, please visit us at orbis.org. If you enjoyed this show, please subscribe to our YouTube channel to watch each episode and check out many other videos about our work around the globe. If you're listening to the podcast version of the show, please hit subscribe so you don't miss a future episode. And if you're listening in an Apple podcast, please consider rating or reviewing the show. It really does help others learn about us, about Orbis, and our sight-saving mission. Until next time.